Good morning. I'm absolutely delighted to finally welcome everyone to the first EMBARC Bronchiectasis Patient Conference. My name is Kjell Hansen. I'm the chair of the European Lung Foundation and one of the co-hosts for the day. So allow me to introduce the co-organizers of the events. The European Lung Foundation is working in partnership with the European Respiratory Society to bring patients and the public together with healthcare professionals to improve lung health and advance diagnostics, treatment, and care. For this conference, our ELF Bronchiectasis Patient Advisory Group have worked closely with the ELF staff to co-organize this event. You'll meet the great people of the Bronchiectasis Patient Advisory Group later in the program. EMBARC is a pan-European network of clinicians and scientists who are engaged in and promoting research about bronchiectasis. EMBARC is the other co-organizer of this event. So together, we are extremely proud to welcome you to this conference. And we are looking forward to sharing this day with you and to engage with you, our attendees. We know that many of you who are attending today have bronchiectasis, are family members to or care about someone with bronchiectasis, so welcome. We also know that many of you are healthcare professionals and researchers who have joined us to find out more about bronchiectasis. To you also, welcome. I know someone with bronchiectasis. It's my great pleasure to introduce you to my brilliant co-host, Bridget Harris.
Hello, everyone. I'm Bridget Harris. I have bronchiectasis and have been a member of the European Lung Foundation Bronchiectasis Patient Advisory Group since 2015, and it's been a great privilege. Many people have bronchiectasis, and many people don't know they have it. They have symptoms, perhaps persistent cough and frequent chest infections, but the cause has not been identified or has been misdiagnosed. I was told I had asthma, and it was more than 10 years before the real cause of my symptoms was found. Even for those of us who do know this is what we have, it can be isolating, especially if we know no one else with this condition and our healthcare professionals aren't familiar with how to manage and treat it. But in knowledge lies power, which is particularly relevant when it comes to long-term health conditions. This conference is to help all of us to understand bronchiectasis better, to learn how best to manage it, and hear about the latest research. The conference is perhaps particularly timely now with COVID-19, which is another challenge to be managed. This is the first ever conference for patients that the European Lung Foundation has worked on, and the response from all of you has been tremendous, with well over 1,000 people registered from more than 40 countries. That is really amazing. And the conference is also an opportunity to engage with others. We want it to be as interactive as possible. And you've already been doing a great job with that by saying hello in the chat and telling us where you're joining from. And it's just lovely. But also, please ask questions. Speakers can't answer questions about anyone's personal circumstances or cases, but otherwise, don't be shy. No question is a stupid question. We really want you to be able to gain the knowledge you need. And if you use social media and Twitter, please do tweet about the event using the hashtag Bronchiectasis 2021. And now to today's program. As you'll see on the slide, there are 4 main sessions and each has 2 co-chairs, a patient and a clinician. They will introduce the speakers, keep them to time and coordinate questions. Time is allocated for questions after each session, but please write your questions in the Q&A box at the bottom of the screen as we go along. We're fortunate in having very knowledgeable speakers, leaders in the field of bronchiectasis, who are all committed to patient engagement, actively encouraging our involvement with the work they do and listening to and welcoming our input. Remember, no question is stupid. Please like any questions you see in the Q&A that you most want answered by using the thumbs up icon. This will flag them up for attention and may help to avoid duplication. The first session is on the basics of bronchiectasis. It's important for us to understand what it is and how it can affect us. After a 15-minute break, the second session will cover treatment and self-management. As with any enduring condition, self-management on a day-to-day basis is the mainstay and therefore very important. There'll be a 45-minute break before we go to session 3 on the latest research, and there is much going on, aimed at improving things for us and for patients in the future. The fourth session is about bronchiectasis and COVID-19, an opportunity to hear disease-specific insights. And now back to Kjeld.
In order to make it through today in a stylish fashion and hopefully without any significant delays, we have decided to introduce a few housekeeping rules. For this event, we have adopted a webinar-style format. It means that attendees can only see the speakers, chairs, and hosts, but not other attendees. But rest assured that they're there. Attendees are also muted, and they'll remain so to avoid interference of sound. We would therefore like to encourage you to participate in the chat and through our Q&A sessions, and you'll find the Q&A button under More in the format. For the Q&A, we encourage you to write your questions in the Q&A board. We will try to answer as many of your questions as we can find time for. Those not answered, we'll try to answer with the speakers after the events and publish the answers on our website for you to access after the events. And we are recording this event. So talks will be available in the ELF website and the ERS respiratory channel after the event for you and others to freely access. So during the events, we will also ask you a few questions. We introduce several polls that we'll be asking you to participate in. And perhaps we can do a test run so you know what to expect. We have prepared 2 initial polls, which are questions that will pop up on your screen just now. You may answer the question and submit the poll. Afterwards, we will share the results with you. If it sounds okay, then I think we'll just get started. So I hope you all have the opportunity to participate in the poll, and then we'll see the results shortly. Good. So we have the results of the first poll, and the question is, are you a patient, caregiver, patient organization, health professionals, student researcher, industry representative, and other? And according to the results, we have a 65% patient representation. We have 26% healthcare professionals. So that's really amazing. Thank you so much. Well, since that went great with the first poll, then I think we should try and introduce a second poll to really get in the mood. So Jess, can you introduce the second poll? So I'm hoping you're all seeing the second poll. Are you a member of a bronchiectasis support group? On your screen now. So please vote. And then we are waiting for the results. Are you a member of a bronchiectasis support group? 41% says no, while 31% says yes. And then there are quite a few, 24%, that says, I don't know of one. And this might be a problem that some people would recognize. So thank you so much for participating in the two first polls. So now I will hand you over to my co-host, Bridget.
And without further ado, it gives me great pleasure to introduce the first session on the basics of bronchiectasis, chaired by Tove Berg and Arietta Spinu.
Hi, I'm Tove Berg, and I'm from Norway. I have bronchiectasis and have been a member of the patient advisory group for bronchiectasis since 2015. I'm so excited. I'm so excited about this conference, really getting to hear the professionals and the patients tell about bronchiectasis. I feel privileged to be a part of this. I'd like you all to meet my co-chair, Arietta.
Hello, everyone. My name is Arietta Spinu. I'm a lecturer in cardiorespiratory physiotherapy in the UK and also a specialist respiratory physiotherapist. And it's a pleasure for me to introduce you to the first session of this day, which will be about the basics in bronchiectasis. So the first talk is going to be an overview about bronchiectasis, where we will talk about what bronchiectasis is, the historical overview and the demographics of this disease. And then the second talk will be about the infections in bronchiectasis and what we currently know and what we're learning. Tove.
I have the pleasure of introducing our first speaker, Pieter Goeminne. And Pieter is a respiratory physician in St. Nicholas, Belgium. His PhD defense was on non-cystic fibrosis bronchiectasis. He is a co-author of many publications on the topic of bronchiectasis, such as the ERS bronchiectasis guidelines. He's also a board member of the EMBARC, which is a register of bronchiectasis for Europe. His further professional interests are air pollution and infectious diseases. The stage is yours, Pieter.
Thank you so much, Arietta and Tove, for this introduction. So I've been given the difficult task to give you a Bronchiectasis 101, an overview of bronchiectasis. We see that there are a lot of patients present today, so maybe not everyone knows about the details of bronchiectasis. And I thought that I would give you an overview of what bronchiectasis is in order to understand better the rest of the day. And I will try to, at the end, position every talk within the pathophysiology, which means the origin of bronchiectasis and how it gets worse, because every talk today fits nicely into a puzzle, which I will show you later on. So an overview of what I'm going to talk to you about, a short historical background. First, I'll go through the healthy lung and then the wide variety of symptoms within bronchiectasis. If you would put resin in the lung, and you would take the lung away, you would have this nice cast of the bronchial airways. And if you put it upside down, it looks like a tree. So you see that the airways become smaller and smaller towards the periphery, and they have a nice tubular form. It has two main zones, the conducting zones, where it mainly conducts air. It has obviously other functions as well, which we will talk about later. And then there's the respiratory zone. And if we think about how bronchiectasis originates and how it gets worse, we think about the vicious vortex. And the vicious vortex is 4 elements. It used to be called the vicious cycle, but we call it a vortex now because each of these 4 elements influences the other elements. And so we have a part of destruction of the lung, we have a part mucus hypersecretion, epithelial dysfunction, and ciliary dysfunction. We have a part inflammation and a part infection. So let's start out with bronchus destruction or deformity of the bronchial wall. Here you can see in the white a bronchus and in the red an adjacent vessel. And this is a micro CT imaging of small airways. And so normally the airway vessel, the red, should be in diameter the same as the bronchus. And here you can see that the diameter of the white bronchus is enlarged. This is what we call a bronchiectasis. So this is typically the radiological definition of what a bronchiectasis really is. The second element that goes wrong in bronchiectasis or in many patients is the epithelial dysfunction, mucus hypersecretion, and ciliary dysfunction. Those are all difficult words, but what it really means on the top left corner is that your airway walls are covered with epithelium, sort of airway skin cells, one would say, sort of the wall of the airways. And then in between you have these blue cells, which we call goblet cells, that produce mucus. And on top of it, you have a hair-like structures, which we call cilia. And so these red cells, the epithelium, the wall, the bricks of the wall, so to speak, are hyperplastic, which means that their cell division is increased. There are more of them present. And by doing that, you can see that the walls lose their nice shape in a certain way. Also, the goblet cells in between are becoming hyperplastic, so more of them as compared to a normal airway, and they are hypertrophic, which means that they are enlarged in size. And the cilia, why are they there? They produce a whip-like motion, synchronous, that will propagate the overlying mucus layer. Just to give you an idea of what a healthy airway should look like. And in patients with bronchiectasis, this is changed, this is altered. And more on that on the talk of Arietta Spinu. There's also an important inflammatory problem in patients with bronchiectasis. As you know, there are many, it's a very complicated thing, inflammation, and in all the inflammatory cells. More specifically in bronchiectasis, white blood cells are very important, as they, as you can see here, chase bacteria down and try to eat them. And in bronchiectasis, we see that this inflammatory response goes a little bit wrong. Here you can see the white blood cell eating the bacteria finally. In search of his next victim. But in bronchiectasis, not only these white blood cells are increased, but the substances they produce are also increased and can cause deleterious effects if it's too much. But more on that in the talk by James. And then there's the fourth element, which is the chronic infection element. On the right side, you see the mucus layer with the cilia. And when it gets infected by these small rods, you can easily see that there is a aberration and destruction of not only the cilia, but also what's underneath. And if this infection is too much, it's sometimes difficult for the body to cope with. And then you can get, as a result, for example, bronchiectasis. Now for a short historical background, and I've seen some questions already on whether the presentation could be in French. So for those French speakers, a little bit of French, because the first person to describe bronchiectasis was René Théodore Laennec, French physician who reintroduced the stethoscope, by the way. And he says that he is the only author of which he knows that talks about bronchiectasis for the first time. Here you can see, aucun auteur que je sache n'en a parlé. And he talks about the fact that these bronchiectasis acquire a diameter, a cuillère en diamètre, that is égal à celui d'une plume d'oie, like a goose plume, or even the thickness of a finger, à même celui du doigt. And he also describes very nicely, just for people who do not, or who have a difficulty of envisaging how a bronchiectasis looks like when you would put it out of the body. He says that these tuyaux bronchiques, these bronchial tubes, are so much dilated that they se terminent par des cul-de-sac ou cellules in little cells or sacs that are capable of keeping logé un grain de cheneville, which is a hennep seed, un noyau de cerise, which is the core of a cherry, or a hazelnut, une aveline, or an almond. So just to give you an idea of how bronchiectasis, when you would cut it open, looks like, and what the shape of these bronchiectasis is, and sort of dimension you can imagine with these examples. Here you can see René Théodore Laennec testing his reinvention of the stethoscope. And fortunately, the last 15 years or so, we have an increase, as you can see, in publications on the topic of bronchiectasis and non-CF bronchiectasis. You can see here that the past 4 or 5 years, there's a drop in the term non-CF bronchiectasis in PubMed, which is the largest database on medical research. But that is because of the fact that we are trying to get rid of the term non-CF. As Stuart Elborn, professor in Ireland, very nicely put it, it is untenable to define something by what it is not. We should define something by what it is. So no nonsense, no non-CF. That means that we were trying, as a part of research, trying to determine the differences between the different patients with bronchiectasis, and hopefully in the future we can talk about, for example, autoimmune bronchiectasis, CF bronchiectasis, primary ciliary dyskinesia bronchiectasis, rheumatoid arthritis bronchiectasis, etc., etc. As you know, and I've just told you, bronchiectasis can present itself in a quite big variety of ways. And one of the varieties is radiologically. It has 3 main stages. Historically, these are still being used. I think they have been described in the 50s for the first time. And in the first stage, if you look at the CT scan, which is now the gold standard, it used to be bronchography, but now it's fortunately for the patients a CT, which is less invasive. You can see that there are cylindrical bronchiectasis are characterized by as you have seen in the 3D image in the beginning, an enlarged bronchus with a smaller adjacent vessel. A normal airway would have the same size as the adjacent vessel, and it looks like a signet ring, a ring with a stone or a diamond on it. If you would cut the tube in its length, you will have a tramline appearance, because normally, as I've shown you with the bronchial cast image in the first slide, the airways become smaller towards the periphery, but in bronchiectasis patients, the airway walls do not get smaller. In the next stage, we have varicose bronchiectasis, because they have a varix-like appearance. The tube shape is steadily being lost, and it's losing its shape, as you can see, having a sort of varix appearance. And in the last stage, we call it saccular or cystic bronchiectasis, because they have totally lost their airway wall integrity, and they have this cyst-like appearance. Not only based on radiological imaging, there's a difference between patients, but also if we look at symptoms. We have looked at all a large part of the studies on bronchiectasis and looked at what definitions they used to include patients in their studies. And as you can see, there is a wide range of different symptoms that can be linked with bronchiectasis. And then we thought, well, all these trials are using all these different definitions. Maybe for the future, we should try to get a consensus of what would be for clinical trials at least, important in the definition of bronchiectasis, which does not mean that in a clinical atmosphere, there are not other symptoms, for example. And this is obviously at the diagnosis, because many patients, when they get treated, they get better, and sometimes some symptoms disappear. But as you can see, cough, sputum, exacerbations, hemoptysis are the mainstream of symptoms in bronchiectasis, but more on symptoms in the talk by Josje Altenburg. Then we come to the definition. We have, you might ask, well, hasn't there been a definition on bronchiectasis? Well, only recently we have thought about trying to define bronchiectasis more in detail, because it used to be a more radiological diagnosis, but we disagreed with this, and we thought that not only radiology should be important in the definition, but also symptoms. And for clinical trials, we say, well, cough most days of the week, sputum production most days of the week, and a history of exacerbation at diagnosis. Then the causes of bronchiectasis. Well, the causes, again, a very big variety of possible causes. Stefano Aliberti in his talk is going to talk about this. But as you can see, some of them are pretty obvious. Post-infectious causes, viral bacterial infections, atypical mycobacterial infections, COPD, which is a smoking obstructive pulmonary lung disease, Immunological abnormalities. If you have a bad immune system, you get recurrent infections, and then you can get bronchiectasis. This can be primary, which is innate, or secondary as a cause of something else. For example, chemotherapy that reduces your immunity and causes infections. These can be congenital anatomical aberrations that can cause bronchiectasis, like tracheobronchomegaly or sequestration. There's also inhalation or aspiration that can cause bronchiectasis. As you can see, there's a very wide range of possible causes. And so calling all these different people non-CF in one and the same group seems untenable. And that's what one part of research is trying to do, trying to unravel this web of different etiologies. Just to show you how sometimes unique bronchiectasis can be. This was a patient, I think in Brazil, who had recurrent pneumonia, localized bronchiectasis. And when they operated this patient and removed the lobe, they saw this, as you can see, ectatic bronchus. And inside was something very strange. It was the etiquette of a flip-flop, Havaianas flip-flop. So this is the first bronchiectasis flip-flop or flip-flop lung, just to show you that very banal things can cause bronchiectasis sometimes. There was also a question about demographics of bronchiectasis. And fortunately, the past 5 years have been a great period because many registries have been online, and I've taken a few registries. For example, the European one, as you can see, many centers participated. If you look at the etiology, which is the middle graph here, the circle, you see that post-infective causes and idiopathic causes are the mainstream of causes for bronchiectasis in Europe. A large part as well, asthma and COPD, and then immune deficiency, rheumatoid arthritis, ABPA, which is allergic bronchopulmonary aspergillosis, primary ciliary dyskinesia in purple, which is dysfunction of those cilia I talked about earlier, and then GORD, which is reflux disease. IBD is inflammatory bowel disease. If we look at the demographics, we see that the European patients are mainly female, 58%, and the average age is 68 years of age. Most of the patients, luckily, have never been hospitalized, but the distribution of exacerbations is ranging from 0 to, let's say, 4 or 5 exacerbations. Fortunately, often patients have a reduction in exacerbations when treatment is started. If we look at the bacteria in the airways, because that's one of the points that Michal is going to talk to you about, Pseudomonas aeruginosa in Europe is the biggest one in about 18% of patients. And this is important. We have a very low prevalence of non-tuberculous mycobacteria, as opposed to America, for example. If we look at the Indian EMBARC database, which is also a very large database, we see that there's a difference in etiology. They have a very large group of post-tuberculosis bronchiectasis because it's more prevalent and present in India. They also have idiopathic and post-infective, which is other reasons, for example, pneumonia. They also have ABPA, but what we are missing here, for example, is we have a big group of primary immune deficient patients, and this is not the case, for example, in India. But for the rest, in terms of hospitalization and the use of oral antibiotics, so exacerbations, it's more or less the same as compared to Europe. If we put the two next to each other and we try to compare them, you see that the age in India is significantly lower. They're younger patients and much more men as opposed to the European data. Whereas in America, you see much more female patients as opposed to Europe, for example. 80% female patients. In Europe, it was about 67, 70%. If we look at smokers, much less smokers in India. However, they had a quite large group of COPD patients, probably because there is quite some indoor pollution due to indoor cooking and use of fires indoors. So the smoke there or the cooking is different in India often. In terms of severity, not many differences between both India and Europe, but you can see that the mild disease is more prevalent in India and the moderate more in Europe, and slightly more severe disease in India. Also, worse lung function in India. And in terms of bacteria, the striking difference is that they almost have no Haemophilus influenza or Staph aureus. but they have a similar amount of Pseudomonas aeruginosa. And if you look at America, the difference, we have 15 to 18% of Pseudomonas aeruginosa, and in America it's 33%. So a big difference there in bacteria. And the data are not here, but non-tuberculous mycobacteria in America is also very high as opposed to India and Europe. And so this final slide, just to give you an overview of today and where each talk is fitting into the day, the rest of the day. We start with the next speaker, which is Michal Shteinberg. She's going to talk about the infection part of bronchiectasis. It's a very important part because we have antibiotics, we have possible treatments that can reduce infection. She will talk about this in this next talk. Then Josje Altenburg is going to talk to you about the symptoms and trying to cut the vicious cycle. So what we try to do with treatment is cut all these arrows and try to hold down the propagation and the viciousness of the cycle, and maybe in the far future going to a virtuous cycle instead of a vicious cycle. Then Ariete Spinu is going to tackle the mucus hypersecretion and ciliary dysfunction. She's a physiotherapist, so she is an expert on the topic. Then we have very important for us some patient experiences. As you know, not only this day, but Michal might give some words on that because she's the chair of the working group who does patient work with the patients and projects with the patients. But we value the experiences of patients very much, and our guidelines, the bronchiectasis guidelines, were, I think, the first guidelines where patients were included as author and were part of the process of producing the guidelines. So this is just to show you how important patients are in bronchiectasis research. Then a very interesting talk about symptom approach, mainly the fatigue and shortness of breath, and how to tackle that slightly from a different angle, different point of view by Dr. Spatis. And then in the center of the vicious cycle is Stefano Aliberti, who is going to talk to you about etiological testing. As I've told you, there's many etiologies. So he will talk you which one should we test, how should we test, and give you more information on that. And then inflammation, the immune system, very complicated thing, and no one better than James Chalmers to tackle immunity and inflammation in bronchiectasis. And then with the 2020 COVID-19 epidemic, we need some words on the COVID-19 and bronchiectasis. First and foremost, how do we prevent? What are the symptoms in bronchiectasis patients with COVID-19? Dr. Gramegna is going to give you a lecture on that. And then finally, how do we organize care and how do we care with patients during this COVID-19 epidemic by Felix Ringshausen. And so I would like to give the word back to the chairs. And thank you so much for inviting me. And if there are any questions, there's a Q&A after Michal's talk.
Thank you very much, Peter. This was a great overview about bronchiectasis, and I think that the audience will now be able to understand all the talks that follow from yours. And you've set the day, and you gave us an overview of the day with the specific areas that each speaker is going to cover. So thank you very much for that. It's a great pleasure now for me to introduce you to Dr. Michal Shteinberg. She heads up the bronchiectasis and adult cystic fibrosis service in Carmel Medical Center, Haifa in Israel. Her main research interests are bronchiectasis and its overlap with other airway diseases, mainly rhinosinusitis and the connective tissue diseases, as well as adult cystic fibrosis. Dr. Shteinberg is a member of EMBARC 2 and leads on the patient activities. So thank you very much for joining us, Michal.
Good morning, everyone, and thank you very much, Arietta, for this introduction. So I'm very excited to be here this morning for the first ever patient bronchiectasis conference. And I'll just start with a quote by Sir Isaac Newton a long time ago, who said, "What we know is a drop, what we don't know is an ocean." And it's 300 years since then, and our knowledge has really expanded, but it's still surrounded by an ocean of things that we don't know. And regarding infections in bronchiectasis, there's a lot of things that we know. We know that it's very common to have lung infections with bacteria, viruses, and fungi. We know that we can use antibiotics to treat exacerbations and to prevent them. We think we know what happens during exacerbations and what determines infection. And I can list 100 things that we know we don't know yet, but I've only listed one, which is what's the best way to prevent chronic infection. And there's a whole lot of things that we don't even know we don't know. Back in December, we were planning this conference with our wonderful patient advisory group, and I got a whole list of questions and requests from the group. And some of the questions you see here on the screen, the range of colonizing infections and what the prevalence, and if we get some weird bacteria that the doctor even didn't tell us about. And finally, what makes a good sample for getting to the labs, and do they check for all of the infections? And a little bit about the lung microbiome. So when planning this talk, I want to talk about why do people with bronchiectasis become and stay infected, the ways that we diagnose infection, how common are infections by different species and the geographic distribution, and outcomes of some infections, and I'll focus on Pseudomonas and non-tuberculous mycobacteria. As Pieter's already mentioned, they're the most well-studied. And finally, some treatment recommendations and tips for getting a good sputum sample. So to start off, why do people with bronchiectasis become and stay infected? And I'll use this wonderful diagram by Holly Ann Richardson and James Chalmers that was published a few years ago. And we know that lungs are not sterile. We know that bacteria come in and get out of the lungs. We know they come in from aspirating from the esophagus and the stomach, from other organs, and by direct inhalation from the environment. We know that the mucociliary clearance, remember the video from Pieter's talk, clears the sputum with the bacteria, and also our immune system kills the bacteria. And also there's a lot of microbes in our lungs that are in competition with each other. In bronchiectasis, there's factors that may increase the coming of bacteria in the lungs, such as more bacteria in the upper airways or sinuses, exposure to hospitals and healthcare environments, and in the lungs, the dilated bronchi and the sputum that accumulates within create a wonderful nutrient and food for bacteria to grow on. It also creates areas where there's high acidity and low oxygen. Some bacteria cannot grow there, leaving the space for more virulent and resistant bacteria to grow. And there's also factors that have to do with decreased elimination of bacteria, such as decreased ciliary function, the ciliary beating that was shown by Pieter, and also plugging and retention of mucus. And I'll talk a little bit about these factors today. But first I want to say, how do we diagnose a lung infection? So normally when you give a sample of sputum to the lab, they grow it on specialized plates called agar plates. And they find little colonies of where bacteria grow, and this is an example of Pseudomonas that is grown on agar. And this method can also show how antibiotics kill bacteria and what antibiotics don't do nothing to these bacteria. So a traditional method was to put a disc of paper immersed with antibiotics. Here you see ciprofloxacin, and there's a clear circle where the bacteria don't grow around this disc of paper.
Michal, can I just interrupt you really quickly and say, is there any chance you could speak closer to the microphone? Because quite a number of people are having a problem. Sorry to interrupt you.
So today, the identification of bacteria is performed automatically by mass spectrometry that is unique for every patient, for every, organism, and creates a pattern of the macromolecules emitted. And this is done automatically. The machine tells us which bacteria is it that we group. So the patients have asked about the microbiome analysis, and the microbiome or microbiota means the whole collection of microorganisms, bacteria, virus, and fungi within a special location. In our instance, it's the airway. It's also known as culture independent because in these methods, we don't actually grow the bacteria on culture. We just analyze the genetic material, the DNA of the bacteria or fungi or viruses. It picks up all the species present. As you see here, there's a lot of bacterial species. And this is by work from Michael Tunney's group in Belfast. And because we see there's so many bacteria in the lungs, we don't really know which of them are important and which of them are causing disease. So this may be too sensitive, and this is one of the reasons, not the only one, that it's currently not in routine clinical practice, just for research. But we've learned a lot from microbiome stuff. First, that the airways are never sterile. There's always some bacteria there, and also that diversity and a lot of type of bacteria is good. If we have lower diversity, meaning less species, it's associated with lower lung function and other poor outcomes. We also know that the microbiota is stable over time. So there's sort of a unique signature for every patient with his own unique spread of bacteria that is pretty stable. So how common? This is a recent EMBARC registry data analysis that we've done just a couple of weeks ago, and showing the most common bacteria among the people with bronchiectasis. It's nearly 19,000 people with bronchiectasis in this database. And you see, like Pieter showed, that the most common still is Pseudomonas and Haemophilus, but also bacteria that are coming from the gut and Staph aureus. And also, I'd like to compare what's common in India and in the United States. And as Pieter said, while Pseudomonas is always the most common organism, there's a lot of differences. For example, there's almost no Haemophilus here and less common in the United States. Another type of infection is non-tuberculous mycobacteria, resembling tuberculosis, same family. They're very slow growing, but they're all around us in the soil and water. They may survive for decades within human cells. They may or may not cause damage to the lungs, so we sometimes choose not to treat. But this is an example of a bacterium that did cause damage to lungs. You see here the hole in the lung, the cavity. And in this case, we would tend to treat this bacterium. Treatment is very lengthy, over a year usually, with a combination of antibiotics. The prevalence of non-tuberculous mycobacteria is very different across different places, and between 2 to 8 to 63%. And while we don't really know what causes us to be infected with non-tuberculous mycobacteria, we do recognize some factors that put patients in risk, like prior use of antibiotics and glucocorticoids. We know that there's a lot of species of non-tuberculous mycobacteria. Some of them tend to produce lung disease more frequently than others. So, for example, if you have Mycobacterium tanzafii, you're more likely to get lung disease than if you have, for example, Mycobacterium burgdorferi. And us clinicians are more likely to treat if we find these bugs than these ones. And the distribution of species of mycobacteria are very different across different countries. For this example, it's across Europe. So the outcomes of infection, and I'll focus on the most studied, which are Pseudomonas and non-tuberculous mycobacteria. And if you as a patient are told that they've found a bug in your lung, what does it mean? And it does depend on the bacterial species. First of all, will it persist and become chronic? Some bacteria tend to stay, but others are transient and go away. And we've done recently research of the Israeli registry and found that if you have one infection with Pseudomonas, 33% chance that you'll have also a second infection with Pseudomonas. But if you have one infection with Haemophilus, you're only 23% likely to get a second infection with Haemophilus. So the bugs are different from one another. And one issue of the bugs that if a bug is infecting the lungs for Pseudomonas, it can surround itself in a gel-like material called the biofilm. And this gel-like material helps the bug evade the immune system and evade and stick to surfaces. And it helps the bug create a chronic infection because antibiotics in our immune system can't reach the bug very well. And this is again from the EMBARC registry. People with a first infection, how likely are they to get a second infection with the same species? So you see 30% with Pseudomonas, but other bugs are much less likely to persist. What does it mean to have a chronic infection? Some organisms are associated with worse outcomes, such as Pseudomonas, non-tuberculous mycobacteria, and fungi. Sorry. So we know that for Pseudomonas, people with Pseudomonas have more daily sputum, and all of these bugs create more frequent exacerbations that are associated with more frequent exacerbations, and also higher mortality. But it's not absolute. It's not a 0 or 100%. We know that exceptions are common, and we know some patients with persistent Pseudomonas who do extremely well despite their chronic infection. So some outcomes associated with infection. On the left, you see for each bug, the risk of having exacerbations compared to patients without this bug. So it's 2.5 for Pseudomonas, but a lot less for the other bugs. And if you have some of the bugs, you're not at all more likely to have exacerbation. Over time, we see that people who have Pseudomonas and Acronobacter and gut bacteria tend to have worsening of their symptoms, while people with other bacteria don't have worsening of symptoms or even improve with time. Who's more likely to get infected with Pseudomonas? So there's one set of data by Pieter Goeminne from the EMBARC registry showing that people who didn't have Pseudomonas at the beginning of follow-up, but did have new Pseudomonas infection over time, were the ones that had the worst lung function, frequent exacerbations, worse radiologic severity, and they were more likely to be treated with inhaled corticosteroids or macrolide antibiotics. And they were more likely to have higher sputum production and have primary ciliary dyskinesia as a cause of the bronchiectasis. And we did a similar analysis and found, again, primary ciliary dyskinesia, but also COPD, and people previously infected with Haemophilus, and also those who abused alcohol. And a little bit about treatment, and I know Yoshi will talk some more about it. So because we know Pseudomonas is bad for you, when we first isolate Pseudomonas in a patient, we want to try to get rid of it, to eradicate. And there's a lot of options, all antibiotics, and some are given orally by pills such as ciprofloxacin, and some are intravenously, and some are given by inhalation. So typically we start with 2 weeks of antibiotics and test again, and if the Pseudomonas is still there, we give a prolonged course of inhaled antimicrobials, and usually we extend it for 3 months. Not every bacterium grown for the first time needs an antibiotic. As you've seen, some bacteria we're not really sure what they do, and so we don't really treat with antibiotics if there's just a growth and the patient is feeling fine. That is except for Pseudomonas. So talking a little bit about exacerbations, many of you know that in the life course of a patient with bronchiectasis, you have ups and downs. You sometimes feel better and you sometimes feel a lot worse. And when you have many symptoms over time, if you cross a certain threshold, you're told to have an exacerbation or feeling ill. It's more sputum, more phlegm, sometimes fever, sometimes blood in your cough. We know that some people, more than others, tend to have exacerbations. And we've already talked about bacteria, but also inflammation and people with asthma and COPD and sinusitis as a cause of their bronchiectasis. And there's a lot of data about vitamin D deficiency causing bronchiectasis exacerbation. What immediately causes an exacerbation is something that we're less sure of. We used to think that a new bacterium causes exacerbation or changes in bacterial composition. We now know that it's not always true because studies have not consistently found changes in bacterial composition at the start of an exacerbation. Then we thought that if bacteria are doing something different, differences in metabolic activity. We know that inflammation increases in exacerbations, and we've identified in some exacerbations viral infections. And Pieter has done a lot of work on air pollution, and we know now that it's causing exacerbation. When ill and exacerbating, we recommend enhancing airway clearance, as Arietta will explain, and we recommend to treat with an antibiotic that's suitable for the bacterium or more than one that is there. Typically, we recommend 2 weeks of antibiotics, but sometimes we give it intravenously or in hospital if someone is very ill. And when people are frequent exacerbators or have frequent exacerbations, and we usually mean more than 2 or 3 per year, and especially if they have an infection with Pseudomonas, we recommend long-term antibiotics given either orally or by inhalation to try and prevent these exacerbations. And the final topic I'll talk about today is some of the tips that give a good sputum sample. So we recommend giving at least once a year a sputum sample, just so we know what bacteria tend to be in your lungs, and if becoming unwell, ideally before antibiotics. We need sputum, not spit or saliva. So the lab does look at the sputum sample and wants to see that there's inflammatory cells there and not upper airway cells. The best way to achieve this for some people is right after airway clearance or after doing the physiotherapy. And sometimes inhaling saline, either isotonic or concentrated or hypertonic, will help. The pot needs to be sterile, of course, and the volume needs to be at least 2 milliliters. And ideally, it should get to the lab within 2 hours if kept at room temperature. But there's some patients who typically don't give sputum in the morning while the labs are collecting the samples. So it may be refrigerated to up to 8 hours, and some say even 18 hours. So you can give us a sample in the evening and then send it to the lab the next day. Will they automatically test for everything? Well, that depends on the lab, and each lab has their own routine. So the physician needs to know the lab that they're working with and needs to specify. Usually, in my case at least, when I write culture, they culture the bacteria, but not the mycobacteria, so I need to order both. When culturing bacteria, typically you get a result by 2 to 3 days, but they do wait longer to test for longer bacteria, slower growing bacteria. And for mycobacteria, they do a direct visualization or smear, and this is what the mycobacteria may look like. It's very quick, you get an answer within hours, but it's rather insensitive. So if they don't see the bacteria, it sometimes doesn't mean necessarily that there's none. And sometimes the lab can give an answer of tuberculosis because they really resemble tuberculosis, but it's actually non-tuberculous mycobacteria. They could do PCR to differentiate from tuberculosis, and also to check for genes that convey resistance to antibiotics. But for growing and identifying the type of mycobacteria, usually it's very, very slow and can take up to 2 to 3 months. So I'll stop here and summarize that infections are very common in people with bronchiectasis, that there's differences across regions, and that some bugs are associated with worse prognosis, like Pseudomonas, that we tend to treat, and non-tuberculous mycobacteria, and that it's recommended to treat the first infection with Pseudomonas to prevent it from becoming chronic. And regarding non-tuberculous, it really depends on the species. Obtaining a good quality sputum is very crucial, otherwise we don't know what we don't know. So finally, I would like to thank you all. I would like to thank our wonderful patient advisory committee, patient advisory group, led by Tanette Boyd from the ELS. And I'd also like to thank Professor James Chalmers, whose idea it was in the first place to have this wonderful conference for patients. And I'll be very happy to take any questions.
Thank you so much, Michal, for the interesting lecture about the infections and especially about how to take a good sample of it, because that's not easy all the time. We're now going over to the question and answers part of this session, and we have really got a lot of questions in the box here, but we won't be able to answer all of them, but they will be answered and put on our website later. So just keep on putting questions in there. The first question that a lot of you are wondering about is, has any research been done on life expectancy with bronchiectasis? Or because of the lack of diagnosis of the condition, is there no data? Peter, would you like to answer this question?
Yeah, sure. So yeah, there has been quite a lot of data on mortality or life expectancy, and it's a little bit too long of an answer to answer in during this talk, but and maybe later on there's going to be some data on it in the next talks. But it really depends also on the cause of bronchiectasis and the comorbidities that the patients have. So there has been quite a lot of databases, and for example, the EMBARC database is also going to research mortality, and there have been some series looking at mortality. There seems to be an increased mortality overall in bronchiectasis patients, but most of it, I would say, boils down to what other elements are present that will increase the probability of mortality. For example, age, obviously, or the presence of Pseudomonas, or the presence of COPD, for example. There have been quite some scores being developed, severity scores. So we have the bronchiectasis severity index, the FACE score, there's the bronchiectasis comorbidity index, and all these scores tell us something about what to expect in a patient. And so the variables that are present, and I've answered it to one of the questions, the variables that are important to determine severity of disease and therefore the probability of increased mortality are not only age and pathogens, but also lung function, shortness of breath, presence of other important comorbidities like COPD, for example, or cancer, obviously. And so all these elements taken into account will then determine whether or not there is an increase in mortality. So it's difficult to just say yes or no. It's a more subtle answer.
Can I add a little bit about you were mentioning the delays in diagnosis and the long time? I think Bridget was talking about it, and we really want to learn more about it. And there's a survey online now about your experiences. So if people haven't answered it yet, I really ask all of you to come in and share your experiences, and especially, did it take long to diagnose your bronchiectasis? Very interesting to us.
Could I answer a question that is not going to be present in any of the talks? And I've seen it a few times pass through the questions. It's a talk about diet. We're not tackling diet during the next talks. And there's a lot of questions about that. Now, my wife is a dietitian, so I'm being slapped around with diets a whole day. So I've thought about this on numerous occasions. I think for bronchiectasis, you need to take into account a few things when we talk about diet. First and foremost, the comorbidities. So, for example, osteoporosis is more present in bronchiectasis. So just make sure your calcium and vitamin D is sufficient in your diet, and try to reduce salt, not just by putting away the salt on the table, but processed foods, for example, have a lot of salt that can reduce calcium. So, for example, breakfast cereals, processed meats, for example, can have a bad impact on osteoporosis. Also, reduce phosphor in terms of osteoporosis. So, soft drinks and caffeine, try to not be too wild with that. That's for the osteoporosis part, because we know it is linked with bronchiectasis and probably also with bronchiectasis severity. Obviously, because it's a chronic inflammatory problem, you will need some extra protein. So often we will try to enrich at least a little bit with protein in patients who are often underweight. There's also an important impact of reflux in bronchiectasis. So there as well, we need to think about changing the diet, not too fatty, because otherwise the reflux might get worse. And we think that it also impacts the bronchiectasis severity. Then the shortness of breath can get worse when you are bloated. So to try to, if you are really having shortness of breath, try to reduce the meals with more frequent but smaller meals. And then there's no research as far as I know, but I know Josje Altenberg did some research, and so the next talk we can ask her on nutrients and bronchiectasis and inflammation, I think. So maybe she has some more data on that. And then finally, I think, and this is something very interesting, people always say, I don't drink milk because it increases my sputum. That's actually a urban myth. There has been actually some research doing placebo, so milk-like beverages, comparing it to milk, and there's absolutely no difference between the two. And there's also not an increased sputum production when you drink milk. So you can drink milk; it's full of vitamin D and calcium, and I think it's important. So don't say it will increase your phlegm, because the research show it doesn't. So again, very complicated answer for a very simple question, but I would say just talk to your dietitian and have a well-balanced diet.
Yes, thank you, Peter. That was very important to discuss. And you actually reminded me of the educational sessions we have in pulmonary rehabilitation classes, where our dietitians advise the people who have bronchiectasis about what they can eat and what they cannot. So you really summarized that perfectly. I have a question for Michal, and then you can also join the discussion if you want. There is a question from an attendee about what percentage of patients also have rhinosinusitis. And given your interest in this area, I would like you to comment, please.
Yeah, so rhinosinusitis is very common in bronchiectasis. It happens a lot, and the percentages, according to different publications, are between 20 to 30%. There's a lot of reasons why it happens. If you have, the most obvious one is if you have primary ciliary dyskinesia, rhinosinusitis is one of the rhinosinusitis in bronchiectasis are both affected. But a lot of people without it also have upper airway involvement. And there's a lot of theory why it happens. It's probably we think of the same bacteria infecting both the upper and the lower area. We can also hypothesize that it's a different type of inflammation, a more allergic type of inflammation that is prevalent in the people with both conditions, rhinosinusitis and bronchiectasis. But it's a common phenomenon.
And I like to add maybe a challenging idea. There has been some data that show that in a very small proportion in patients with chronic rhinosinusitis, nasal wash shows bile acids. So maybe reflux also has an impact there.
I was thinking that you wanted to say that macrolides help both rhinosinusitis and bronchiectasis. So there's a lot of
and reflux
that macrolides do all. And also, if you have severe chronic rhinosinusitis and you get operated, you get better lung symptoms. So we get an improvement in exacerbations and lung symptoms. So it's one airway from the nose to the sinuses and the lungs, and you have to treat both upper and lower airways.
Exactly. That's very important to highlight because it is actually one airway we have and it's a continuum. We cannot separate it. And we do, for example, we as physiotherapists, we do look at the sinus and the nose and if it's blocked and what we can do about it. It's very important not to underestimate what's happening in the upper airways as well. Thank you very much. Tove?
Yes, there's a question that quite a few are interested in. It might be about diet too. I am underweight and not able to increase my weight. Is there a minimum calorie requirement for bronchiectasis patients? Thank you.
That's a very difficult question because minimal requirement of calories depends on many factors. It depends on your length, weight, and also on your work of breathing. So I would say talk to a dietitian, try to calculate your basal metabolic rate, and you will have to increase it as your basic metabolic rate is going to be higher if you have an active chronic inflammation, systemic inflammation due to your bronchiectasis or an increased work of breathing. And then you will have to tackle with your dietitian what your target calories are going to be. And that's very difficult for these patients because if you are short of breath, it's also difficult to eat because eating with a full mouth, which causes a hampering of breathing. So I would say there are ways to calculate this, but you will need to do this with your dietitian. She will look at your weight, length, gender, and then calculate your basic metabolic rate, will increase it with a percentage because of your underlying disease, and then that's your target.
Thank you, Peter.
Thank you. And there was another question about how serious is bronchiectasis, but I think that you already covered this by saying there's different severities, and we already have the severity indexes available where the doctors can calculate how serious the disease is for a specific patient. So that's fine. I think we don't have more time for questions, but
there are many questions. We are trying to answer them as we speak. So I see James answering, I'm answering. All the panelists are currently trying to answer the many questions people have. So this is great to have so many questions. So,
well, that's good. And the questions will be put on the ER in the ELFA website too. So thank you for getting your questions in there.